Welcome back to Decode Healthcare with Harshal. If you were here for part 4, you know we successfully navigated the windpipe and the bronchi. But today this explainer is taking a massive leap. We're finally moving past the airways and diving directly into the chest cavity itself. We're going to tackle the lungs and pleura CPT code range, specifically codes 32035 through 32562.
So, I've got to ask, are you ready to enter the chest cavity? This is where medical coding gets incredibly dynamic and, honestly, kind of fun. Today, we're going to explore the complex coding guidelines for things like thoracentesis, chest tube insertions, and managing the incredibly delicate pleural space. Here's our roadmap for today's explainer. First, understanding the pleura. Then, thoracotomy codes, thoracentesis, chest tube insertion, chemical pleurodesis, and finally, a quick teaser for VATS. Let's just dive right in. All right, Section 1, understanding the pleura and the wet balloon analogy. Okay, so before we look at a single CPT code, we need to picture the anatomy in plain English. The pleura is basically a double-layered sac surrounding the lungs. The absolute easiest way to visualize this, imagine your lung is a tightly clenched fist, and you push that fist into a wet, slightly inflated balloon. That balloon wraps around your fist in two distinct layers. The inner layer touching your fist, well, in our body, that's the visceral pleura touching the lung itself. The outer layer on the outside, that's the parietal pleura touching the inside of your ribs. Normally, there's just a tiny microscopic bit of fluid lubricating those two layers so your lungs can just glide while you breathe. But, in our patients, things go wrong. That tiny space between the layers can fill up with excess fluid, blood, or even air. And that is exactly why the procedures we're coding today exist in the first place. Looking at the gross anatomy, you can see the right and left lungs sitting perfectly inside the chest cavity. The pleural space is that microscopic gap wrapping all the way around these lungs, sitting just inside the ribcage. When surgeons have to get into that space to drain fluid or re-expand a collapsed lung, they're operating directly in this incredibly sensitive area. Moving on to Section 2, thoracotomy codes, which is all about opening the chest. So our incision codes live right in the range 32035 to 32225. A thoracotomy is exactly what it sounds like when you break down the medical terminology. Thoraco stands for chest, and tomi means cutting into. So this involves a surgeon making a large, open surgical cut straight through the skin, the muscle, and going right between the ribs. They are physically opening the chest wall. Now, this approach is highly invasive. It's used for major surgical access to the pleural space, like, say, when they need to do an open exploration or a major drainage of a cyst or an abscess. Which brings us to Section 3, thoracentesis, and what I like to call the golden guideline. What's really interesting is how simple but incredibly effective this procedure is. During a thoracentesis, a doctor simply pokes a hollow needle or catheter right through the patient's back, sliding it smoothly between the ribs and straight into that pleural space we talked about earlier. Now, why do this? Well, it's because the patient has accumulated fluid that's literally trapping their lung and they just can't breathe. The doctor attaches a syringe or a drainage bag to that needle and simply pulls that excess fluid out. The lung gets room to expand again, and the patient feels this absolute instant relief. But here is where you, as a medical coder, have to be absolutely razor sharp. This is the golden guideline. You absolutely must read the operative report to see if imaging guidance was used. Did the doctor use an ultrasound or fluoroscopy to safely guide that needle into the pocket of fluid? Because if they just did it by feel and anatomical landmarks, you're going to report code 32554. But if they used imaging guidance to watch that needle go in, you report code 32555. Literally, one single detail completely changes your code. So never ever guess, always check the op report. All right, Section 4, chest tube insertion, fixing a collapsed lung. To really understand chest tubes, you first have to understand a condition called a pneumothorax. In plain English, a pneumothorax is a collapsed lung caused by air leaking into the pleural space. Remember our wet balloon analogy from earlier? Imagine instead of fluid, air gets trapped between the two layers of that balloon. That trapped air creates immense pressure, pushing inward, crushing the fist, which is the lung. The lungs simply cannot inflate against that pressure. It's a terrifying medical emergency for sure. So how exactly does a surgeon fix this? The steps are actually beautifully mechanical. Step 1. The surgeon makes an incision and literally shoves a thick, flexible plastic chest tube right between the ribs, directly into that air-filled pleural space. Step 2. They hook that tube up to a suction machine, which is often called a water seal or a Pleuravac canister. And Step 3. they turn on the suction, which quite literally sucks all that trapped air out of the chest. Once the air is gone, the negative pressure is restored, forcing that collapsed lung to beautifully reinflate. Let's look at the specific codes for this procedure. If the surgeon does this as an open procedure, which the CPT book officially calls a tube thoracostomy, you're going to use code 32551. But a lot of the time, it's done percutaneously, meaning just through a small puncture in the skin. And guess what? Our golden guideline is back. If they do a percutaneous pleural drainage without imaging guidance, the code is 32556. With imaging guidance? Yep, it's 32557. I really cannot stress this enough. It is absolutely vital that you scan that documentation for terms like ultrasound guidance to ensure you land on the right code. Moving right along to Section 5, chemical pleurodesis, intentional destruction.
Now, chemical pleurodesis sounds kind of terrifying, I know. Pleurodesis literally means binding the pleura. This is the process of intentionally scarring the two pleural layers together to prevent fluid from ever building up there again. When a patient has a severe condition, like cancer, for example, that causes their chest cavity to just constantly fill with fluid, draining it over and over again just isn't enough. We actually have to shut the space down entirely. And how did they do this? Well, it's incredibly fascinating. The doctor literally injects a chemical agent, most commonly something like sterile talc powder, straight down a chest tube into the pleural space. Now, that talc is highly irritating. It causes massive intentional inflammation on both the visceral and parietal pleura. As they heal from that inflammation, those two layers stick and scar tightly together. And if there's no space between the layers anymore, fluid can never accumulate there again. It's an aggressive but absolutely brilliant fix for persistent fluid. So for our destruction codes, we're looking at the 32560 to 32562 range. If the doctor is instilling that talc powder for pleurodesis, you're going to report code 32560. Now, sometimes they aren't using a chemical to scar it. Sometimes they instill a fibrinolytic agent to break up thick, stubborn, separated pockets of fluid, which we call multiloculated effusions. If they do that, it's code 32561 for the initial day of treatment. If they have to come back the very next day and administer the agent again, just to keep breaking up that fluid, you report 32562 for the subsequent day.
And finally, Section 6, a quick teaser for VATS, looking ahead to Part 6.
We've covered the open thoracotomies, the needles, and the chest tubes. But what happens when the surgeon wants to operate inside the chest without making massive cuts? Well, they use tiny cameras. Coming up next in Part 6 of our Explainer series, we're diving into thoracoscopy and VATS. That's video-assisted thoracoscopic surgery, covering codes 32601 through 32674. Make sure you're subscribed to Decode Healthcare so you don't miss it. Until next time, always check for that golden guideline. But before you go, think about this. How exactly does a surgeon safely navigate a tiny camera inside a beating, breathing chest cavity without causing a pneumothorax? We'll uncover that mystery in the next Explainer.